Good afternoon to everyone and welcome to today's session. I hope that you are able to catch up with 180 minutes 240 race of the NEET mock test. The whole idea is to get that habit of solving every question within 45 seconds of time, which you are all very sure about, and the good part is there is no negative marking. So we invite all of our online students from Kurnool, Kadapa, Warangal and many more who are online and offline. So let's make the start. If you look at the trigeminal nerve, it ultimately supplies the motor supply to the muscles of mastication. It also will supply the sensory innervation to the lower lip and chin and the cheek and corneal reflex. But the point of interest here is, if you look at the motor fibers, they originate from a different nucleus which is called as the motor nucleus fundamentally. So the motor efferents which supply the muscles of the mastication typically are distal to the trigeminal ganglion, hence they won't be affected is what need to be fundamentally remembered. Now what passes through the foramen rotundum is a very important issue here. Basically it is the mental nerve which is the continuation of the inferior alveolar branch of the mandibular nerve, which is the sensory innervation of the lower lip and the chin. So that is the reason maxillary nerve is the one which passes through rotundum. Mandibular doesn't pass. It is the mandibular which supplies ultimately the skin of the lower lip and the chin, hence it won't be involved if the foramen rotundum is being injured or maxillary nerve is being injured is what need to be fundamentally remembered. Now if you look at the lacrimal gland, this is one of the favorite questions of the examiner, very important question of the examiner. What regulates the lacrimal gland? There are postganglionic parasympathetic fibers in both the maxillary and also ophthalmic division. Both of them will go and ultimately innervate our lacrimals, hence we have tears for our fellow man's miseries of life. So that's the reason it is not only one nerve. There are two sources for the parasympathetic innervation. For the lacrimal gland is what we have to basically appreciate. What innervates the palatopharyngeus? It is the vagus which supplies all the muscles of the pharynx, including the palatopharyngeus. Now doctor, ventroposterolateral nucleus and medial nucleus, VPM, VPL, what is the main difference? Fundamentally, any nucleus of thalamus, what is its job? It is like receiving NEETPG applications. It's a sensory, afferents are received by thalamus. It is the examination body. So there are different specifications. If you want to apply from Kerala, there is a different clerk working. So the VPL receives the afferents which are the ascending sensory tracts of the body, like spinothalamic and dorsal column, which carry our pain, temperature, proprioception, etc. They all will be reaching VPL. Whereas VPM receives all the sensory feelings that we get on the skin of our face typically, and the taste, the vestibular input, which is important for the balance and equilibrium, they all basically reach the VPM, not the VPL, is what you have to ultimately remember. Now tell me doctor, I am shooting a question to you, you must give me one confident answer. We welcome all our online students to actively participate and shoot their answers, because it is the exam time. Another 6 weeks, very good. Our Warangal students say digoxin is the one which leads to nausea, vomiting, diarrhea, blurry yellow vision, etc., etc. Now tell me doctor, if you look at the ventral horn, there is a somatotopic organization of our sensory fibers which are passing through, motor fibers which are passing through the ventral horn. So if you look at the motor fibers which go and supply the trunk, they are more medially located, whereas those which supply the distal muscles of the appendages like the hand, they are typically more laterally located, is a very, very important finding. Tomorrow some of you are going to do MD General Medicine, DM Neurology, and you have a patient who has got a mass lesion in the spinal cord and it is compressing the anterior horn cells. Now there is a division of thought. Why this guy is having only involvement of the truncal muscles with the sparing of the hand muscles? The reason is the tumor is more centrally located and pressing the medial fibers. You have another patient, you are the DM neurologist, dream of that and start preparing, doctor. So then you have a tumor, the guy's hands are paralyzed, but the trunk is not, truncal muscles are not affected because the tumor has started from lateral aspect. That's the reason somatotopic organization of the fibers is very, very important to be understood. Now, when you pass the lumbar puncture needle, very simple common sense question of the housemanship, through what does it pass? At least you must be in a position to answer. It doesn't pass into spinal cord. So it passes through dura mater, arachnoid, ligamentum flavum, but not posterior longitudinal ligament is what need to be remembered. Where is this posterior longitudinal ligament fellow is located? It is extending vertically, connecting the vertebral bodies, and it forms the anterior wall of the vertebral canal. It is not pierced because after all, into which space are you doing the lumbar puncture, doctor? Fundamentally, you will be drawing the CSF from the subarachnoid space of the vertebral canal is what need to be remembered. Now, if you look at the pain temperature, yes, spinothalamic tract is involved. Not even proprioception. Proprioception is by dorsal columns as what need to be fundamentally remembered. From where does the fibers of the ulnar nerve? The root value is very, very important. The ulnar nerve is a branch of the medial cord of the brachial plexus and it originates from the C8 and T1 is what need to be remembered. A computer operator developing the hypoesthesia on the skin overlying thenar eminence. Very standard clinical vignette in any entrance exam you go. Typically, they are vulnerable to the carpal tunnel syndrome with the median nerve involvement is what I want to underscore to all of you. Now you have a garden variety of 20 questions spread in anatomy. Take it as my word that axillary, ulnar, radial, median, musculocutaneous. You must know everything, anything about these nerves. One question is guaranteed, whether you are writing it day one exam, morning session or evening session, doesn't matter. Any session of any of the 14 days war, like Kurukshetra, you may be third day aspirant, fourth day aspirant, doesn't matter. One question on the brachial plexus injury is guaranteed, and not answering that is also a guarantee for not getting a seat. So that's the reason today only you should read doc. Now, when lower brachial plexus is involved, clumkies versus herbs, you must know the difference. It is the small muscles of the hand which are most often involved is what I want to underscore to all of you. Now I am shooting you a question. Who will give me the correct answer? Procainamide or propafenone? Or P for, we already got an answer, procainamide. That's good, that's good. It is the procainamide. If the atrial fibrillation is because of WPW. You can't give digoxin, verapamil or adenosine, which are the traditional drugs for the AF or SVT. You can't give them if the AF or SVT is because of aberrant pathways. Why? Because these three drugs, digoxin, verapamil, adenosine, how do they prevent SVT? You don't want SVT to go into ventricle. You want to create refractoriness in the AV node. So the main job of these three drugs is to create the refractoriness in AV node. But if you increase refractoriness in the AV node in WPW patients, what is the problem? The aberrant pathway conduction become more, and it is the aberrant pathway conduction which is responsible for the SVT in them. So you don't want the problem to get worsened. So don't give any drug which can increase refractoriness of AV node and increase conduction through the aberrant pathway. Hence you use procainamide, because procainamide selectively inhibits only the conduction through the aberrant pathway, and hence treats the AF of WPW syndrome, is what need to be remembered. I think in somewhere in the middle we have shot up. So for every student who enrolled with us, we have the entire video library. Just you need to take the username, password, you need to demand from us and take a username, password. You have got in the medicine cardiology folder. In that you click on cardiology, you are having all the lectures of the cardiology organized topic wise. In that go to the SVT topic. We have parroted it. So in the past 15 years we have no other job than to teach the same things for different groups of students, that's all. So that is the reason, doctor. The good thing is, now since exam is online, people will also agree online tutoring, e-learning. We are progressing into 21st century, 22nd century. No need of sitting for morning 8 o'clock to evening 8 p.m. in a crowded classroom in a live session with 500 to 600 classmates and sleep half the way and wake up. Here you can interact, you can debate, you can interact with your other classmates. Everything is possible. So that's the reason now we are planning to organize some good quick comprehensive sessions on every Wednesday, Thursday, Friday. We got very good teachers in pharmacology, microbiology, etc. A quick comprehensive review, live interactive sessions on midweek as a complement, because online learning is scalable. There is nothing need to be organized. One teacher delivers, it reaches the world. So when it is cheap for us and easy for us, it is also should be cheap and easy for you. So that is the whole idea.